don't have makeup today. We're going to do part 2 of the vagina, which is discharge. If you remember in part 1, we were talking about pain, and there'll be a few things that I'm going to briefly recap at the beginning of this talk that we talked a bit about last time, but we'll talk about them in more detail today. But just as a brief reminder, because if you're anything like me, like a reminder of something you heard a month ago is always very helpful. So in terms of vaginal discharge, we're going to talk about some of the common causes. We're going to talk about some of the rare causes, and we're going to review a few special cases that I think would be relevant, and I'm always happy to be stopped and ask questions, although I will acknowledge that on the view that I'm on, I can't see if you're asking questions, so if anybody just wants to kind of shout out any questions to me, I would happily appreciate it. Let's see if this is going to show me grid video here or a chat. Okay. Okay. So in terms of an approach for this, what I'm going to suggest is that the first thing you want to do when you're talking about a patient that's got a lot of vaginal discharge is that this often fits in within a broader context of the patient having either vaginitis or vulvovaginitis, which is kind of why I call these two talks, the vagina part 1 and part 2, because it's a little bit difficult to completely separate these things. So the first thing that you want to do is to identify the exact anatomic site of discomfort. So that is to say, are they exclusively having vaginal discharge, or is there an issue where they're having vaginal discharge and pain, or vaginal discharge and itching? Once you have done that, you want to evaluate each symptom separately. So if they're having pain, where exactly is the pain? If they're having itching, where exactly is the itching? And how copious is the discharge, et cetera. And you want to consider whether or not there's more than one condition present, because typically we like everything to be wrapped up into like a single bundle where we can say, okay, well, they have Candida and I'm giving them Canestin and problem solved. Like a lot of yeast infections, for example, shouldn't have pain. So what you want to do is make sure that you're not trying to write off other symptoms from what you're doing, because you want to make it all into one package. So it's possible, and in many instances, these patients have more than one diagnosis simultaneously. The next thing that you want to do is to evaluate the vaginal secretions, and this can be done with pH testing and wet mount, in addition to vaginal swabs. I didn't put the vaginal swabs here because everybody's always taking a swab, but the pH testing and the wet mount isn't done as frequently. So I want to kind of put a bid out for considering this as part of your workup. Finally, you want to bring patients back for a 2 to 4 week reassessment after you've done your initial intervention to see whether or not they're getting a response, because a lot of patients do use a lot of over-the-counter medications. There's more than one thing happening at the same time. They'll initiate their own treatments for this because it is so very prevalent and common. And so you just want to have a good sense of how your particular intervention was effective. And if the patients have their symptoms persisting, then you want to bring them back in. You want to reevaluate for additional causes. So they may have gotten partially better, but not completely. This may be because you're treating one problem and not their secondary problem. And so you want to bring them back in, reassess, and potentially perform a biopsy. If it comes to taking biopsies, it's always appropriate to phone a friend if needed. So the first thing I'll talk about is what is normal in terms of vaginal discharge. So for a normal woman of reproductive age, it's somewhere between 1 and 4 mils per day. Typically, young girls, prepubertal, will not have any discharge at all, and menopause is a whole world unto itself, so I would have to have a separate conversation with you about menopause, but for premenopausal women, that's about 1 to 4 mils. The discharge should be clear or white. It can be thick or thin. And it is mostly odorless, so there shouldn't be a strong smell with it. But there may be a bit of an odor, but that odor should not be offensive. This can be altered by the age of the patient. So we talked about like before puberty and postmenopausal, the point of time during their menstrual cycle, because there is some menstrual variation with this, whether or not the patient is pregnant, because there tends to be a lot more discharge during pregnancy, whether or not they're on the oral contraceptive pill, because this also can alter the discharge. In some people, it makes it more copious. It often makes it quite a bit thicker. Some people are affected by dietary issues, and particularly in terms of the smell, and sexual activities, medications that they may be taking, and generally stress. So to go back a little bit to talk about lactobacilli, so what's normally going on in the vagina. So I just wrote that lactobacilli like it hot is just a way to remember. But to recap what we talked about last time, the lactobacilli are the normal bacteria that we like to see lots of in the vagina. And the way that this works is that a younger, healthy vagina has lots of glycogen in it. So glycogen is getting sloughed from the cells that are just getting sloughed naturally from the vagina. This glycogen makes an excellent substrate for the lactobacilli. The lactobacilli proliferate. The lactobacilli themselves generate hydrogen peroxide and can convert glucose into lactic acid. This gives you a nice low pH on in the vagina. It creates a nice acidic environment, and then again this reinforces what's going on with the lactobacilli, because the lactobacilli thrive in the acidic / hot environment, and then you have lots of proliferation of lactobacilli, and everybody's vagina is happy. So in an ideal set of circumstances, you will have a pH somewhere between 3.5 and 4.5, maybe a little over 4.5, but definitely under 5, and that is a healthy pH for the vagina. So there are testing strips that you can have that will allow you to test for the pH from the vagina. And they will allow you to know like where you are in terms of the range of the pH. pHs that are getting to be too acidic can reduce fertility, and this is because the normal pH of the sperm is somewhere between 7.8 and 8. So if it becomes very, very acid, then the sperm will not survive. And then when the pH is too high or the environment is too basic, then what you find is that other types of bacteria, not the lactobacilli, which thrive in the lower pH environment, start to thrive, and this is when you can have a lot of different kinds of infections and a lot of abnormal discharge. So I'm sure you guys are very familiar with the basic swabs that we do. So the NAT swab is the nucleic acid amplification test, and this is the swab that we do for GC and chlamydia. And typically you want to take one from the cervix and one from the vagina. There are 2 that come in the kit. The key for an effective result from this is to have patience. You need to leave the swabs in place for quite a few seconds in order to get a good result back. So I find a lot of times, because it is awkward, they've got a speculum in place, some of the patients are not very comfortable, there's a tendency to kind of want to put it in and spit it around and pull it back out. So usually what I do is, particularly with the cervical swab, is I'll put that in first, and then I'll spend some time trying to open the charcoal swab, because you're usually doing both at the same time. Those are notoriously hard to open with gloves on. So by the time I've got that open and I'm ready to take my charcoal swab, I've usually left it in the cervix and in the posterior fornix for long enough to get a good result back from the NAT swab. And then with the charcoal swab, typically you want to take, this is the one you're going to use for BV, Trichomonas, Candida, GBS. You want to take this from the posterior fornix. You can use a cervical swab in order to get wet mount, or if you want to also check for GC at the cervix. But using a charcoal swab for GC is really not something we do too much right now, so I don't think you need to be as concerned about the cervical swab. But this can also be used if you're going to do a wet mount, which I'll talk about a little bit in a moment. So a wet mount is just a slide that you make where you can use a dropper to place one droplet of water in the center of a slide. Then you take your charcoal swab that you've taken your little vaginal sample from, and you put a small thin section of the sample on top of the drop, and then you take a little slip cover and you put that over the sample, and then you kind of angle it as like a hinge so that it spreads out the sample evenly under the glass, and then you can take a look at it under a microscope if you have one available to you in clinic. And this can be really helpful to give you like an instantaneous answer on what type of discharge it is that you have. So if you look at the top, you can see the little swimming Trichomonas. At the bottom, you can see the branching hyphae of a yeast infection. And over here, you can see the clue cells that you quite often see with GC. So when we talk about causes of abnormal discharge, there are some that are very common, and there are some that are significantly less common. So we talked about a few of them before. Other causes of abnormal cervical discharge would include things like cervical cancer, other STDs, diabetes, people using douches, scented soaps, bubble baths, and I wrote locations here, and I think I meant to say something else. It probably auto-corrected me. But what I mean is that people who put a lot of different things in their vagina that should not be there. Also, you have patients that can get PID, Trichomoniasis, Vaginitis, vaginal atrophy, and yeast infections. So in anything where there's a common cause, usually there's kind of a big three. And so I'm going to talk about the big three first, and then I'm going to talk about other common causes after that, and then we'll talk about some of the rarer causes. So BV is the most common cause of vaginal discharge that you will see. It accounts for 40 to 50% of the cases. Interestingly, though, many patients who have infections that would be considered BV actually don't have any symptoms from this whatsoever. BV causes there to be a really complex change in the biota of the vagina. So what happens is you get a reduction in the hydrogen peroxide producing bacteria, so those are the lactobacilli. You get a dramatic increase in the anaerobic gram-negative rods. The pH starts to rise and rise, so it becomes more basic, and this can be profoundly affected both by the age of the patient. So as you have less estrogen in your vagina, and there's less glycogen in the vagina, therefore, and so there's less of the glycogen for the lactobacilli to feed on, so they don't thrive as well, and then you get an overproduction of the gram-negative rods. Then you'll see the pH start to rise. So quite often, older women, perimenopausal or menopausal women, will find that they have an abnormal vaginal discharge. We do also see variations by ethnicity, and so I don't know if I'm going to talk about this later, but there's been some interesting early research done in the Aboriginal community, because many Aboriginal communities, particularly the ones that are more isolated, have unique bacteria that we don't see in the rest of the population. Like they're biologically unique, but they do fall under the classification of bacteria that we know. So there are variants on Clostridialis that I have written over here. There's variations on Gardnerella as well, and there are variations on Candida, the different subtypes that we don't see in the larger population. But unfortunately, there's not been a lot of research in this area, so it's harder to know the full extent of this because the research has been so limited. But I can tell you, like from American data, for example, in the Black population, that we see like much higher rates of these types of infections in the Black population because they're simply more susceptible to it. So the most popular bacteria that's the cause of bacterial vaginosis is Gardnerella. So most of you will already have heard of Gardnerella, but it is not the only. So I've written a list here like Prevotella, Mycoplasma, Bacteroides, Ureaplasma, et cetera, et cetera. So there are a great number of bacteria that can cause bacterial vaginosis. It does not simply equal Gardnerella, but Gardnerella is certainly the biggest offender. With respect to BV, risk factors do include sexual activity. We see it more commonly in patients that have other STIs, but it is unofficially a sexually transmitted infection in and of itself. It's not officially a sexually transmitted infection, and the reason that it's not officially a sexually transmitted infection is because there is not a single causative agent, and they have not been able to find a natural reservoir in men. So these are some of the criteria that would allow us to call something a sexually transmitted infection. However, when they look at aggregate data, people who get BV have been sexually active. Typically, like it's unusual, you would not typically see BV in somebody who's had no sexual activity. And it seems to be made worse with frequency and type and number of partners. So there is definitely a relationship in terms of sexual activity. And then we see this a lot too when we look at relationships between women and women. So if you have two women, the rates of BV actually go up. Because each woman has her own biosphere, and so what you see is in a new relationship, them getting BV is quite common, but then as the relationship moves forward and they actually exchange bacteria, there becomes a new normal and the symptoms subside over time. It's also associated with race and ethnicity, as I had mentioned before. Douching and cigarette smoking are two big risk factors as well, so we try to discourage both of those things. In terms of presentation, you get a fishy odor and a thin white discharge. It should not independently cause pain. So if a patient is having the discharge but there's no pain, then that is fairly classic for BV. If they're also having pain, then you want to consider whether or not there may be other causative factors. So we see here that the vaginal culture shouldn't play as much of a role as doing the wet mount, which we encourage, but we do have commercial tests available. Gardnerella vaginalis specifically is key to creating sort of a hostile environment within the vagina because it has the capability of creating a biofilm. So if you look at this film, like if you look at the bottom here down at B1, what you get is that you have like a sort of, it creates a strata, like a scaffolding that along the vagina in a film, and then all the other bacteria can like land on this scaffolding and just start growing and growing and growing. So if you get overinfected with Gardnerella, that is when you can have multiple types of gram-negative bacteria in the vagina. So when you look at patients that have BV and you look at the number of organisms that get cultured from the patients that have BV, patients that do not have BV have somewhere between 1 and 6 types of bacteria in their vagina with an average of 3, but the patients that have BV have between 7 and 20 with an average of like 12, 13, 14, around there. So there's significantly many more strains of bacteria in somebody who has BV, and that's partly because of this biofilm that can be created by the Gardnerella in the vagina. So Candida, this is number 2 in our big 3. So yeast infections are very common. What you see is that there's a lot of itching, there's a lot of discharge, but 10 to 20% of patients are asymptomatic. So that's kind of a little bit the opposite to the BV patients, because many people have BV, they may be asymptomatic with it. Most people who have Candida actually have symptoms. most of you probably feel very comfortable treating Candida because it's common. In terms of the treatments, both the topical and the oral treatments have similar effectiveness, but the oral seems to have more side effects, and the topical is typically better tolerated. So if you're going to treat topically, the important point to know is that you cannot just treat the outside, even if the symptom that the patient is having is pruritus and it's external, and that's why they want to be treated. If it's not treated vaginally as well, the vagina just becomes a reservoir for the yeast and it will not resolve. So what you do want to do is have both a vaginal and a vulvar treatment. This problem of patients that keep getting infected over and over again is present in about 15% of patients, and this can be a little bit more complicated to treat. So if the patient develops complicated Candida, then it is more convenient to treat it orally often because the repeated vaginal application can become onerous for patients. So you may want to consider switching to an oral treatment for that. If it's persistent also, you may want to consider testing again because the less common variants, so most of the Candida infections are caused by Candida albicans, but there are actually a wide range of different types of Candida, and they don't all respond as readily to fluconazole. So you may want to consider whether or not you have a less common variant. So you can treat with one of the other azoles, so that might be miconazole, itraconazole, ketoconazole, one of the other zoles. Some effect has been shown with boric acid, so you may have patients coming in and saying that they looked online and they tried boric acid. The boric acid has shown some effectiveness, but it's not considered to be equivalent to one of the antifungals as yet because we don't have longitudinal data on its safety, and the effectiveness is only comparable to the antifungal, standard antifungal agents, so it's slightly less favored, but it's not ineffective. It does work. If you have tried all of these things, and your patient still has persistent disease, then you may want to phone a friend because there are more powerful agents that we can use, but I wouldn't really recommend those in like more remote or more lower resource settings to be trying these more advanced medications. What you can do locally, though, is if a patient has developed persistent disease and they need to be treated, you can treat them over a longer period of time. So quite often what we'll say is that you're going to do 150 or 100 milligrams of fluconazole for a couple of weeks and then use it weekly 200 for up to 6 months. So you can try a longer treatment like that, and it is often effective in a certain subset of patients that have developed a reservoir. Some of these patients, though, will become resistant to fluconazole. The other thing to remember is that there have been quite a lot of things found in the literature in terms of increased rates of miscarriages with fluconazole, so you want to be careful about using fluconazole in a patient that's at high risk of getting pregnant or who is actively seeking a pregnancy. So trichomoniasis is number 3. So after BV and Candida, number 3 is Trichomonas. It affects about 5 to 7% of patients in low-risk settings. But when I was looking around for data, it seems that in more isolated communities or more at-risk communities around the world, not just in Canada, it's more like 16%. It's interesting, too, because whereas some of the other infections, you don't see them as much in older women, Trichomonasis has a bimodal distribution where you see it in women in their 20s and again in their 50s. So you can get burning, pruritus, dysuria, lower abdominal pain. About 10 to 20% of women infected will present with symptoms, and getting infected with Trichomonas and with something else at the same time is quite common. So I did show you a little picture of the little flagellae there. Okay, so these are the slightly less common ones now after we talked to the big 3. and number one of those is gonorrhea. So gonorrhea usually, when it presents with a discharge, it's usually within about 10 days of exposure. You get a mucopurulent discharge. There's often vaginal pruritus associated with it. The patients often get cervicitis, and the cervicitis can cause there to be extra discharge or extra bleeding. Sometimes postcoital bleeding will be the complaint. There are extremely high rates in certain isolated Aboriginal communities, particularly ones that are further north. So the Canadian data that we have shows that we see about a 10-fold rate than the base population. So there's like a really strong logic for doing routine screening on young sexually active women. Chlamydia, what we often see is cervicitis. 85% of patients are asymptomatic, so only 15% are symptomatic. If they are symptomatic, what you get again is a purulent discharge, and patients may have recurrent episodes after the initial infection. So quite often, they will have repeat episodes of postcoital bleeding or abnormal menstrual cycles and dysmenorrhea. So again, you want to encourage people having routine screening if they're sexually active. So to talk a little bit about the older women now, we'll see atrophic vaginitis. So we'll see this when the estrogen levels decrease and we're seeing the rising pH. And so there's a lot that you can do to help these older patients that are having atrophic vaginitis and abnormal discharge because of that. So they can use lubricants, so those can be either water or silicone base. You can use extra virgin coconut oil. You can use olive oil. Last time somebody was asking me about the blue Crisco. I did look it up. It is kind of a thing. So I guess blue Crisco is the option, although it doesn't seem to be the option that is most commonly used by like the expert groups that I'm involved with, but it is a known thing and apparently it's pretty effective. I haven't seen a lot of literature behind it, but it seems to be harmless, and if it's working, that's great. Estrogen. Like nothing really works like estrogen, but there are many patients where you cannot use estrogen. All the topical forms of estrogen are essentially similar in their effectiveness, but they have different price points. So you may want to consider that in terms of the choice. So what we also have now are a few extra treatment modalities that are newer in the past 2 to 3 years. So we have the SERMs, which are the selective estrogen receptor modulators. So the old SERM that you would be familiar with is tamoxifen, which is what we used for breast cancer patients. But that's not really what we're suggesting for the patients with atrophic vaginitis. There are two products that have been brought to the market more recently, ospemifene, which is Osphena, and bazodoxifene, which is Duaviv. And both of these are SERMs that are specifically directed at atrophic vaginitis. The Osphena has been proven to have no evidence of any increased risk of breast cancer. So for patients who are concerned about using estrogen, they get the benefit of it acting like a friend at the vaginal level, and it's helping the vagina be more well estrogenized, but it is not giving you any increased risk at the breast. And so the way that these selective estrogen receptor modulators work is that they downregulate in one area and upregulate in another area, which is why sometimes with tamoxifen, it's downregulating at the level of the breast, but you'll get endometrial cancer because it's upregulating at the level of the vagina and the uterus. But we can exploit this to our advantage in terms of helping to manage patients who have perimenopausal or postmenopausal atrophy. There's less data with Duaviv, but I think that that's just a question of time, and I think that we're going to see similar data as this plays out. Presterone is Gynotrof, this is another steroid type management, and it can give you really good lubrication. And finally, there's radiofrequency thermal therapies. I don't believe this is covered by OHIP right now, but the idea behind it is that you use a laser to increase the level of collagen within the vagina. I would say that empirically, I've seen a lot of patients get a lot of satisfaction from this, but I don't know that we have actually the evidence in the literature to really support it, which is why I don't believe it's funded with OHIP at this time. But empirically, a lot of patients do seem to get a lot of satisfaction for that. If you wanted to do that, patients would have to go to a private clinic. So then with diabetes, you can see high blood sugar levels that can cause glucose to be excreted via the urine, and that causes people to get a lot of yeast infections. And so in diabetic patients, we'll often see a lot of abnormal discharge because of that. And so the key to controlling it is really to control their blood sugar. But if you can't do that, we can treat them with yeast infection treatments as we would with any other patient. Okay, so to go on to some of the more rare causes or things that people don't know about, so they don't diagnose them because they haven't heard of it. So there's such a thing as discriminative inflammatory vaginitis. So 8% of patients that have symptoms with chronic vaginitis actually have this discriminative inflammatory vaginitis. It's often misdiagnosed as Trichomonas. It is associated with a greenish-yellow discharge, itching, burning, redness, and some dyspareunia. The pH is usually over 5, and on microscopy, you'll see leukorrhea. So patients can be treated for this with a 4 to 6 week course of 2% intravaginal clindamycin, or sometimes intravaginal estrogen is somewhat helpful. You can consider compounding this with clindamycin, if that's not effective, then you can try treating with 10% cortisone cream. So some of these patients are very difficult to treat and require maintenance therapy. And if it comes to that, this is again when I would say like phone a friend. It's a rare diagnosis. You might have had less comfort in dealing with it, but it is something to consider in a patient that you've tried all of your standard approaches and they were all ineffective, and you're seeming to have difficulty culturing the agent that's even causing all of these symptoms. This is something to consider. Graft versus host disease. So again, this is like a much more rare diagnosis, but if somebody has had a bone marrow transplant, 25 to 50% of them will actually get graft versus host disease. It can cause itching, dryness, and dyspareunia, and a lot of burning with urination. It can often be treated with non-hormonal lubricants or topical or vaginal steroids, estrogens. This is one where you definitely need to phone a friend if you think that that's what's going on. The main thing is I just want to introduce you to the idea that it can happen, because patients that have been so sick that they require bone marrow transplant do have all of these vaginal symptoms, but they tend to feel like the vaginal symptoms are nothing compared to everything that they've had to go through leading up to the bone marrow transplant. But it can become like really significant in terms of their quality of life if left to its own devices over time. So you just want to be aware that this can happen, and to let an oncologist or gynecologist take a look at the patient. So I'm going to talk about a couple of special cases. So I'm going to speak briefly about prepubertal children and pregnant women, because I know that all of you are dealing with usually the whole range of the community. So these are patients that the general gynecologist doesn't always see, but you have to take care of them. So I just want to give you some hints and tips on these patients. So with prepubertal children, when you get a discharge, they don't typically have a discharge. So when they do, there's usually a reason for it. So these reasons are often sometimes congenital abnormalities, if they have an infection, if they have poor hygiene, and you may think that I am totally against bubble baths. I am not. It's just that they can cause a lot of grief. So bubble baths, shampoos, and other types of irritants, obesity, and foreign bodies, as well as dermatologic conditions. So I just gave an example here with a safety pin in the vagina because there are a range of items that like to go into the vagina of children, and a safety pin is actually pretty popular on the list. Number one is actually toilet paper. But what they like to put in is toilet paper, little toys that they have, different kinds of Lego, any kind of safety pin, paper clip, and then sometimes they will put those little tiny batteries in there, and that last one is a real problem. Mostly they get non-specific vulvovaginitis, and this is 25 to 75% of cases, and when they get that, what you'll see is that there's a little bit of a lack of labial development. They often have hypoestrogenization. They have a very alkaline pH. But you'll also see this more in patients that are obese and ones that have a choice of clothing where the clothing is very tight. So what we encourage is like less kind of the sleeper pajama and more of like a little cotton nightie and only cotton underwear. Daily warm baths, so where you let the child soak in the bath for 10 to 15 minutes, and then you soap them down and then rinse them off so that they're not soaking in the bubble bath for a long time. And the organisms that we see most often are Candida and Gardnerella, but we also see STDs, and if that is done, then obviously you want to consider whether or not there's been sexual abuse. If they do put a foreign body in their vagina, we can sometimes remove it with just irrigation, but if you're going to actually have to enter their vagina, then we often recommend that it be surgical because it becomes quite difficult for the child. But there are a few positions that you can put the child in that are a little bit less threatening. You usually always want to have a parent supporting them through all of this. We sometimes will see other things when they have systemic illnesses, so these can be measles, chickenpox, EBV, scarlet fever, mycoplasma pneumonia. All of these can be associated with an increased discharge. Pregnancy increases leukorrhea. The cause of this is to prevent ascending infections. So as you all know, it's very rare to see PID in a pregnant woman, although they can get infections, rarely PID, and this is because of this increased leukorrhea to prevent the ascension of the bacteria. And towards the end of pregnancy, they may have like a jelly-like discharge, which is called show. So there are a lot of increased risks in pregnancy with many of the usual pathogens that I was talking about. So screening is really critical. So gonorrhea is associated with chorioamnionitis, pre-prom, preterm birth, low birth weight, small for gestational age babies, chlamydia with prom, preterm birth, low birth weight babies, trichomonas, the same three. The only one that's not really associated with all of this is the Candida. But I had mentioned earlier, just be careful with the fluconazole because we can cause increased miscarriages by trying to treat the Candida. And so I think that that comes to the end of my prepared slide. I'm happy to answer any questions.
Thanks so much. Is there anything out there? There's nothing.
Hi.
Wow,
I have a very quick question. Can you hear me?
Yeah, I can hear you.
Yeah, so it was a lot of information which I really feel I need to go over, but it says that it's being recorded. Is it possible to get the recording? Sorry, it's because we're at work listening, so it's
Yeah.
So,
I think the recording is going to be posted to the website. I think Ben is going to post the recording.
okay.
It is a lot of information, but I felt like you guys see vaginal discharge all the time, so like I can't be like, yeah, people have discharge.
No, so no, but honestly, so we hear more vaginal discharge than we see, but the information will allow me to ask more questions.
Yeah.
So thanks.
You're welcome.
Yeah, just a reminder, in the email that went out with the logon information, the link for the website is there, as well as the link for the recordings, as well as past sessions. This one will be posted probably within the week. Go ahead, sorry.
I have a question. Do you have the experience of women that have had sexual abuse in their background, and then they seem to come in, they have a lot of irritation of the vagina, they pain, all of that, and everything else has been ruled out. Do you see that?
Yeah.
Yeah, what can you advise about that? I know rule out the things that can be.
So in some of these patients, like where it's chronic like that, you may want to consider whether or not you want to take a biopsy just to see if you can get a little bit more information, if you feel comfortable taking a biopsy. If not, you may want to, as I was saying, like phone a friend. But they have had probably like a change in the, like an alteration in the biome of their vagina that is like really hard to overcome. So like sometimes with these patients, I will consider whether or not they want to try like a vaginal like lactobacilli suppository. They do have them on the market. It's a little bit questionable how well those work, but I've had some success with that, like where patients seem to do a bit better.
Restructure their biome?
Yeah. Because the alteration in their biome is a big part of what's gone on, right?
Yeah.
They probably became infected with something, but it was silent, like a long time ago, right? So the biome's been altered.
And when it's vascularized, right?
Yeah. Yeah, but I do see that a lot. It's very challenging because it's also difficult to examine these patients. They're uncomfortable.
Yeah.
And so, like, I'm always a little bit torn. I don't know how you feel as a clinician, because I often need to be checking things and getting biopsies and doing swabs, but then sometimes I feel like I'm adding to the trauma of the patient. So, because intellectually they know why I'm doing it, but then I feel like I'm sort of breaching the therapeutic relationship if I have to do things that are going to be a bit painful.
Because you don't want to, if you start to talk about, you don't want to re-traumatize them by getting them to recount it. Right?
Exactly. So, like if I feel like it's going to be too difficult, I have the luxury, which you guys may not always have, of taking people into the operating room. So I do a lot of work in Moose Factory. So in Moose Factory, I do have access to an operating room. So sometimes, like if I just need to get a little bit more information, I'll quickly do an examination under anesthesia and get all my information that way. So it just causes like less trauma to the patient. So if you guys have like a visiting gynecologist or something like that, and that's also a good time for like the other team members to join, because you can examine the patient collectively. To do some exams and stuff like that, a quick EUA, because it's just so hard, like when they've already had a lot of trauma and the exam's already difficult.
It is very. I guess we can ask the doctors if to refer. Not gynecologists. They never do that in Winnipeg. They never put anyone to sleep or anything like that. But I think maybe asking to request it.
Yeah.
Yeah. Okay. Thank you very much.
You're welcome. Any other questions? Oh, I see there's something in the chat here. Hold on. But I can't see the chat. It's the Survey Monkey.
Yeah, sorry.
That's okay. I was finally able to figure out the chat, so I was quite excited about that. All right. Any other questions?
So if there are no further questions, then I guess
okay, can you hear
very much. Oh, yes, yeah, we can.
I wanted to ask a question about the tamoxifen. Is there any further research done on it? Because if there's people who are skeptical about having it just in case they have any cancerous anything related to cancer. Is there any further research done on that medication or other medication used for vaginitis?
Oh, so what I was saying is, let me just go back to that. What I was saying is that with the tamoxifen, we use tamoxifen pretty routinely for breast cancer, so we know a lot about tamoxifen. But what they've come out with more recently are two other medications that are in the same class as tamoxifen. So it's not the tamoxifen itself, but it's two other medications that are in the same class. So of those two other medications that are in the same class, the Osphena and the Duaviv, there's a little bit more cancer information and long-term information on the Osphena just because it's been out a little bit longer. And the information that we do have from that is that because it downregulates at the breast, right? So it's not going to cause you the same risk of breast cancer as if you gave that patient an estrogen. So women like estrogen because it makes them feel fantastic. Like it's like the fountain of youth. It's like everybody's happy hormone. But the problem with it is that it can sometimes cause people to get other cancers. That's the concern anyway. So what you can get around with Osphena and Duaviv is that they don't have the same concerns at the breast, but they can get a lot of the same benefit at the level of the vagina to get better estrogenization of the vagina without risking getting breast cancer. It's just that one of them has better information to suggest that it's safe than the other one. But as far as we know, both are safe. One just has more information.
Thank you.
You're welcome.
Okay. I'm leaving some space this time in case any final questions. Okay, so if we have nothing more, thank you very much, Dr. Pennington.
You're welcome. And I hope you guys get an opportunity to look over this as a little resource for you. I really enjoyed looking at all the different areas. Thanks for the opportunity.
Thanks so much.
All right.
Thanks,
bye.
everybody. Have a good day.